Okay,
Perfect. Thank you. I appreciate you.
no problem. So I wanted to start off with a patient example of a 33-year-old female with a history of migraines coming to my clinic, started about 6 months ago, but she had a car accident with a whiplash injury. She has a new headache that's different from her migraines. It's dull, it's non-throbbing, right? Not really a migraine description, and it happens at 2-week intervals. Starts in the left side of the neck, goes to the left forehead area. The migraine medications don't work. Neck stiffness, decreased neck movement, and she was given physical therapy with no improvement of symptoms. So this is kind of a classic description of what we might see in a cervicogenic headache. And so this is the x-ray of the patient, right? It's completely normal because, sometimes nerve injury doesn't show up on x-ray. So here we see an x-ray of the cervical spine. We're looking at it from a lateral view, so from the side. And you can see here the bones line up pretty well. There's very minimal degenerative changes. This is a typical kind of x-ray we might see in a young individual who has a whiplash injury. And so what do we do at this point? So we have to think about the spectrum of headache, right? We think about migraines and how, they have that kind of pulsatile quality to them and they're treated in a certain way. And then we have other headaches like trigeminal neuralgia that have a certain distribution, along the jaw or along the head. Tension headaches, the most common kind, are bilateral. They may have dull kind of non-specific symptoms. And really another common cause of headache is analgesia overuse, meaning that patients are just taking too much medication. And so the treatment for this is actually withdrawal of medication for a few months. So other than that medication overuse, these headaches above are really, again, on a spectrum of symptoms, right? Migraine might present as kind of like a pulsatile in the headache and jaw, as does the trigeminal neuralgia. Tension headaches may be similar to migraines, but they may be different. And every patient presents differently. This is another even bigger differential diagnosis, right? Like, is neck pain radiculopathy, and radiculopathy meaning a nerve issue? Is there issues in the jaw, like a TMJ issue, right? That can cause jaw pain. That can cause issues in the headache. You'd be surprised how herpes zoster can cause issues on the neck, especially if you don't look at the skin. Is it to do with the joints in the neck, arthritis in the neck, myofascial pain, muscular pain, or is it a rheumatologic disorder, right? Do patients have fibromyalgia that can present as headaches? Sure. And then we see on the bottom, again, a number of different headache disorders that we're going to talk about how to differentiate, but how does that fit, into the general category? So when I see a cervicogenic headache, right, I'm thinking about all these headaches at the same time. I'm thinking about what is this differential? Importantly, we had to think about aneurysm. There are vessels in the neck that can present as a headache, and it's something that needs to be ruled out. What I mean by posterior cranial fossa is there's, a set of structures in the base of the kind of the skull that can connect to different structures in the neck. And you could have a tumor, right? You could have an inflammation in the area that can replicate a headache. So it's important to differentiate. And you can have what's called neck-tongue syndrome. And so there are different nerves that actually course close to the side of the neck. And so some patients who have arthritis or other conditions, a rapid turning of their neck can actually cause numbness into the tongue and a headache. So there are other causes as well. So it's actually very difficult to really determine if this is a true cervicogenic headache or not. So, even C2 neuralgia, again, this is another nerve issue. So again, these are so many things that headaches can present with. And so what about cervicogenic headache? So there's two different thought processes. There's a clinical diagnosis and there's an interventional diagnosis, or where we can use procedures to help determine the etiology of a headache. The current international headache classification gives this criteria for a cervicogenic headache. And you have to have a clinical imaging evidence of a lesion in the cervical spine, right? Like, let's say it's an arthritis, or let's say it's an injury like a whiplash, like a known issue. And the headache needs to develop in relation to that issue. So if the issue happens, the headache needs to develop after the issue. It can't develop before the issue. That's not a cervicogenic headache. It's improved when that cervical issue is treated. You may have reduced range of motion in the neck. And most importantly, and what's bolded, is that the headache is abolished following a nerve block. And so that's really important. And so I wanted to go over headaches, looking at it all at the same time to kind of illustrate what I've been talking about. So on top, we have signs and symptoms. Cervicogenic headache, CPH is chronic paroxysmal hemicrania. HC is hemicrania continua. And these two headaches are headaches that essentially can continually affect people for multiple times a day. Cluster headaches are those that can appear in men more commonly than women, and they present with runny nose, teary eyes, pain behind the eye, and it can be a reasonably common headache in men. Migraine headaches, as we all know, throbbing, pulsatile, can have visual or aura, hearing aura, and then tension headaches, which are kind of your classic everyday headache. And so they're all unilateral, right? The plus sign meaning that they're there, right? Female, sure. I mean, cluster and tension, okay. And if you look at all these, I think the point is it's virtually impossible to tell the difference in headaches if you just ask somebody where it is. It's very difficult, right? And all of it sounds the same, right? In cluster headaches, it's pain in the forehead. In migraine headaches, it's pain in the forehead. In, CPH, it's many attacks. In hemicrania continua, it could be many attacks. So it's a difficult thing to differentiate. So how do we do this? So we think about range of motion, right? In cervicogenic headache, range of motion is decreased. That's unique. Mechanical, so some are mechanical. Trauma, usually cervicogenic headache, right, happens after a trauma, a known cervical lesion. Shoulder pain, well, that can appear in a few things. Anesthetic, meaning it responds to a nerve block. We know that cervicogenic headache does. That's a big factor. And this is interesting. So stands for indomethacin, and indomethacin is like a very strong ibuprofen. It's a very strong non-steroidal. And CPH and HC actually exclusively respond to indomethacin. So it's it's a kind of a medication we can use to help differentiate. And then SE is sumatriptan or ergots, which help abolish migraines. And obviously migraine and cluster actually respond to those. So we can use anesthetic blocks, nerve blocks to help us tell what headache it is, or we can actually use medications to help us differentiate based on patient response. So there's a little bit of trial and error sometimes in figuring out the actual cause of a headache. And autonomic symptoms, meaning runny nose or teary eyes, usually it's in cluster headaches, sometimes in migraine. So again, this can't really be used to differentiate, but really range of motion, anesthetic, and medications can help. And so those are some of the things we try to look for in cervicogenic headache. So what is the gold standard? It's a controlled X-ray guided diagnostic block. And this is a very kind of complicated picture, but this is the cervical spine, and these are labeled structures. And what I circled here are kind of two common structures that may cause a cervicogenic headache. And again, any structure can really cause it. It can be from the discs, it can be from the joints, it can be from some of the muscles that might help, it can be some of the vessels. Again, there's so much real estate in the neck that you have to take all these consideration. And if it's from the neck, we can use a nerve block at each level to determine where the headache's coming from. And again, these are just pointing out different locations that can produce a cervicogenic headache. So there's studies that happened years ago where they actually injected normal saline. So they kind of just like put a lot of volume of fluid in different areas in the cervical spine. And they wanted to see where patients complained about pain. And so if you look here on the left, C12 meaning like almost to the skull, the topmost cervical spine segments, cause pain in the distribution that's kind of color labeled. The C2 to 3, you see how that differentiation can change, right? It's going a little bit more to the back, a little bit more to the ear, a little bit more to the forehead. And in C3, 4, it kind of keeps moving down. And as you keep going down the cervical spine, the distribution of this pain changes. And so this study was kind of landmark in showing that, well, maybe sources in the spine can cause a headache. And well, why is that? It turns out that the nerves in the upper cervical spine, so the C1, 2, and C3, right? Nerves work in that they emit signals from a peripheral source. So the peripheral source meaning outside the body. And they converge and they synapse or produce signals at larger nuclei. And these larger nuclei then relay messages to the brain. So when the C1 to C3 nerves relay their chemical signals after there's pain or whatever it is, they converge on these bigger nuclei that go to the brain. Those bigger nuclei, just so happenstance, also go to the forehead. So it turns out the upper 3 cervical spines and the forehead nerve or the trigeminal nerve share a common nuclei that go to the brain. So that means that pain from a cervical source can translate to pain in the forehead. And this is kind of the etiology, that kind of pathophysiology of the pain and exactly why it may happen. And so we have the study previously that kind of showed in real time that if you inject saline or an irritant, you can cause pain. And now we know that there's actual neuronal link between the forehead and potentially areas in the upper cervical spine. And again, this kind of highlights the, circling those areas. And so there's what we call a neuroinflammatory cascade. And so when you think about migraine, right, and what we do to treat migraine and how this is important. So migraine is thought to happen when there's some sort of insult or some sort of inflammation that causes a cascade of effects that releases chemicals that can cause your blood vessels to get large and more of these pro-inflammatory pathways that can produce pain. And so all those chemicals are kind of released together when a migraine happens. And the medications that we currently use for migraines actually target a lot of these different chemicals. So CGRP is actually those monthly injectables used for migraine are actually target CGRP. Sumotriptan actually, which is a common migraine medication, actually prevents that vasodilation. And so these things also are proposed as a concept in cervicogenic headache. And again, that idea that headaches exist on a spectrum, they may not actually be individual entities. And a diagnostic nerve block, think about that picture I showed. We can place a little bit of lidocaine or local anesthetic at each of those joints. And we can even activate the disc via a procedure called a discogram to see if that produces pain. And we can tell if pain is worse or better, what might be the source of that cervicogenic headache if there's an injury. The other differentiation is the occipital nerve. And I don't know if who's had this type of headache, but it's essentially a headache. It can be in the back of the head and you can do a quick nerve block. So again, it's another structure that can help. We can use a nerve block or local anesthetic and numbing agent to help us differentiate. The other aspect is, of course, physical therapy, which is commonly involved in headache management. So again, this illustrates, and it's a complex picture, but the places we can block and the different anatomy. And so the first joint on top, the LAA, is the lateral atlanto-occipital joint. This branch here is a sensory nerve that goes to the cervical spine. We can block that. And this C3-DMB is also another sensory nerve that we can block as well. And so these are common areas that are targeted in procedures that can be helpful. And again, highlighting those. And so really it comes down to, can we use those procedures to treat, or should we treat conservatively? And the answer is you really always start conservatively. And so what does conservative therapy mean? There have been no drugs proven for cervicogenic headache. BOTOX is placebo. Studies have not been consistent. You have used TENS units, or those transcutaneous electrical stimulations, which can be helpful from time to time. But again, there's no proven data to show that it is. Physical therapy has been very helpful for these headaches. And there have been many studies that have reported headache frequency reduction and pain relief. And specifically with exercises, with mobilization, with manual therapy, I'm sure there are people here on this call who have experience managing these type of headaches. But I do think physical therapy is an excellent first option for patients with a known cervical source of pain. Cranial motion, cervical flexion exercises, motion segments in the cervical and thoracic spine have all been proven to be helpful. And these are just some manual manipulation techniques and thrust techniques that may be employed. And of course, this is very specific to the patient. Every patient will present differently. And so each therapy session should and would be tailored to that patient, but it's a great start. What about other things? Trigger point injections may have temporary relief. Those are used for more muscle pain. Again, of course, the physical therapy is always recommended for function. Can we use psychology, non-pharmacologic interventions? Sure. But usually as an adjunct, again, no kind of proven benefit. But in the state of chronic pain, mood disorders are a very big deal. And so I always encourage my patients to have psychology, to have mental health therapy, because that's honestly the most important thing. Well, what about targeted therapy? We talked about the greater occipital nerve. That's the nerve in the back of the forehead that we can block and sometimes can replicate cervicogenic headache. So it's an important target. There's that joint at the top of the neck. There's the disc at the top of the neck. And there's the joints in between the different cervical spine. And all these can cause issues. So we can target them. And we do a procedure called a radiofrequency neurotomy. And this procedure targets those sensory nerves in the neck and can actually use a heating probe to burn them off and provide pain relief for a long period of time. We use this procedure after we've shown that a diagnostic block provides pain relief from this headache for the patient. And so we kind of use this targeted therapy to help guide our eventually therapeutic therapy, which is the radiofrequency neurotomy. Again, this is usually after a course of physical therapy or if really everything else we've done has failed. And third occipital blocks are, again, another sensory nerve in the neck. And studies have really shown that it can provide complete relief for patients for around 6-7 months. And so really, if we target the right level, there's been excellent evidence to show that it can provide good relief. And so I think that's important for patients to know. This is an example or a picture of a radiofrequency neurotomy. So you actually see the probe on the left here, and it's kind of targeting this area. And so this is between the C2 and the C3 joint. And essentially we can target and we can burn that nerve off if we've shown that using numbing agent provides relief. And I think that's a really important kind of therapeutic tool we have. And so I wanted to, again, visually represent kind of what we've talked about in the presentation. And if a patient has occipital pain and that pain is starting in the neck, and you have to consider the differential, right? Is it anything else that could be in the neck? Any of the structures, any of the nerve issues, any of those weird disorders? Okay, it's not any of those. Could it be a cervicogenic headache, right? Is there a known trauma? Is there a known cervical lesion? Have we ruled out a lesion in the posterior fossa, like a tumor or some sort of inflammation? If not, then get an MRI. Figure that out first. That's more dangerous. Is there an aneurysm? Is there a blood vessel issue, right? No, but if there is, get an angiogram, figure it out. Is it a kind of continuous pain that may be different? Consider some other nerves, right? Block that nerve and really kind of figure out, is it from the neck-tongue syndrome? Is it from a vessel? Is it from a mass lesion? We really have to make sure that we're considering the important differentials first. But if all that's been ruled out, right? No, then you think about these questions. You think about back to the criteria. Is it varying in duration? Is it non-throbbing? Is there neck trauma? Is there reduced range of motion in the neck? And we're starting to see these things come together. Then sure, maybe it is a cervicogenic headache. And the first thing you do is exercise therapy. It's physical therapy. It's targeted manipulation. And if they're relieved, great. Then that's the treatment and the patient can come back. If not, then we start to target different procedures. So the C2 to 3 joint is thought to be the most common source of cervicogenic headaches. So we can perform a little nerve block. If that works, we can do a radiofrequency ablation. No, the second most common is actually the joint above. So we can block that. And if that's okay, then if that provides relief, then actually the evidence is to do a joint fusion at that particular location, but you could also do a radiofrequency neurotomy. No, then you kind of keep going down the cervical spine. So the C3 to 4 is next. And this has all been shown in research, which is great because we know what the most common target is. We know what the second most common target is. We know what the third most common target is. And if it's a C3-4 joint, then you can do a radiofrequency neurotomy. And so we can keep kind of piecing together what might cause it. And again, this just keeps illustrating that same point. We can use targeted therapy to help patients after a course of physical therapy and after we've ruled out the wide differential diagnosis that comes with headache and neck pain. And if none of these help, then probably should reevaluate, which sometimes can be the case. So, what are some future directions? Typically diagnoses with a radiologic evidence of injury, kind of tying that together and really making sure that, providers like myself or other providers making this diagnosis really take that into consideration. There's always new directions in pain management. There have been studies using stem cells, using monoclonal antibodies to help with pain. I think that's always a future direction. But more importantly, this is difficult to diagnose. And as I demonstrated when comparing a large variety of headaches, we really need better criteria for all of these. What is unilateral? What is throbbing? What are we looking for in X-ray diagnoses? What counts as an X-ray lesion? How do we differentiate migraine versus cluster and all these new treatments coming out? So I think it's an exciting field, but it's one that, we still have quite a bit to learn about. And so conclusions, cervicogenic headache is a secondary headache with a known cervical cause. It's a final common pathway for neck disorders, right? We're thinking about the convergence of those neurons with the trigeminal nerves in the head. And also thinking about headache as a spectrum, right? All headaches might fit in the same spectrum of disorders. There is a clinical side and there's an interventional side where we can use procedures to help with diagnosis and treatment. And there is evidence-based treatment and therapies to help with this type of pain if we can prove it. So these are just a bunch of references I used. Yeah, gonna list this quickly, but these are just a list of office locations. I'm primarily in Silverdale and Gig Harbor. And I wanted to open the floor for any questions and thank you guys for your time. Really appreciate it.
Dr. Batta, there are a few questions, or one question in the chat.
Yeah. I think there's definitely a role for chiropractic therapy. I think what we want to do before a chiropractic therapy is to make sure that it is nothing more dangerous. And what I mean by that, if there's some sort of aneurysm or vessel disorder, if there's some sort of lesion in the brain that's causing it, or if a patient has like a rheumatoid arthritis and there's some increased mobility in the cervical spine, or they have a history of cervical fusion, right? There may be other things involved. So I would say, I think chiropractor does have a role and a very important role, but it needs to happen after dangerous things have been ruled out to not harm a patient. So the next question I got was, how many visits are required before you get a sense of what's going on in a specific patient? That's, I think, a very difficult question. I think it depends on the information that I'm able to acquire before the visit and like documentation, imaging, outside referral sources, anything that procedure-wise is done so far. Usually if we can go through some of these things and the dangerous things, again, like aneurysms or, all these other things that have been ruled out, then sometimes we can do it on the first visit. But, if there are, other health issues or, other kind of medical, symptoms going on, then it's going to be difficult to just say in one appointment, I could figure it out. We may need to actually get more information. So I think pain is pretty complicated. And I think patients often have multiple things going on. And so I try to have a very comprehensive view, especially on that initial visit. Yeah, so for neck exercises to strengthen muscles, I think the biggest thing is posture. And so I think quick exercises are actually just practicing holding your head for just up against a wall. So just holding up that neck straight for just a period of 15 or 30-second intervals, a few times a day. You can also just practice, just putting a little bit of tension, just making sure, you're just stretching and holding your neck up as much as you can. The other thing you should think about is your workstation. It's often important to make sure you have the right computer height, the right keyboard length, from the desk. Make sure you're using a standing desk. Make sure you're changing it up. The other thing you may, be able to do is to simply do some, chin rotation, and positioning, particularly when you're lying down as well. And so I think there's a lot of exercises just with posture that can be helpful. But I think the biggest thing is making sure your workstation is set up appropriately. The next question I have here is Kaiser Permanente in their network of providers treating cervicogenic headaches. I think any pain provider can likely manage this condition. And I think if Kaiser has that, then they should be able to evaluate, but I'm not actually sure. And cluster headaches. So if you have a cluster headache, the medications used, and if they're helpful, cervicogenic headache is a different realm of treatment. So nerve blocks aren't usually done in cluster headache from my knowledge. Cervicogenic headache, because there's a cervical target or a neck target, then you can use that type of procedure. The only thing I know that works additionally for cluster headaches is using the high flow oxygen for a period of 15 minutes, or to take like some blood pressure, calcium channel blockers to help prevent the headaches over time. But it's a very different kind of treatment pathology. Of course. All right. Are there any? Okay. Good question. So with cervicogenic headache, no. I do think electrolytes and dehydration likely play a factor. I'd imagine that there needs to be some sort of trigger for headaches, whether that's electrolyte imbalance, whether that's making sure we're hydrated, whether that's stress. I think stress plays a huge role in headaches. I think alcohol can play a huge role in headaches. I think medications can play a huge role in headaches. So I think, yeah, I don't know if any particular research that points dehydration specifically to headaches, but I would imagine that if your body is stressed in some way, that can cause any headache to be worse. No problem, of course. All right. And then I think for Leslie, who was asked about the neck strengthening muscles, there are actually a really good book you can get called Treat Your Own Back by Robin McKenzie. And it actually talks about all these different exercises that you can do on kind of like an everyday basis. And it talks about not only for the neck and that positioning on the wall, but also for the back and just quick ways you can do it, even in just lying down flat on the floor. And so I think, if you have any issues with just daily exercise, I think that book is actually pretty helpful. Some patients have had good success with it. Any additional questions? Good question. I think it could be a spectrum of injury. And I think that's why the, criteria should be a little bit better specific. But yeah, I mean, it could be, just like being struck on the head. I've just seen it in the sense of a whiplash, because that's a pretty clear source. And then patients kind of come in and are like, oh, I had this injury. But yeah, I mean, it could be arthritis from the neck, right? It could be any number of injuries. So yeah, it could be a very small trauma to being from a car accident. That's an excellent point. So I think that's part of why taking a really good medical history is just something I do on the first visit to try to really pinpoint what started this pain. What were you doing that day? Were you doing something in the yard? Were you lifting something different? Was your workload increased around that time? So I really try to piece together what may be the cause of it.
Can you hear me?
Yes.
I was wondering what kind of correlation you see between cervicogenic components with patients who present with some sort of vertigo pathology.
Yeah, that's a great question. So interestingly enough, when you do some of those radio frequency neurotomies, especially in the upper cervical spine, you can actually anesthetize some of the muscles, which like the kind of subitalis area that can help with balance. And so some of the procedures can actually, one of them can be like a balance issue for just a short period of time. But yeah, I mean, I think, and the question was with vertigo, I think it definitely relates. And I think that there are many structures in the posterior cranium. So like you think about like the brainstem, or you think about things that connect pretty closely to the neck, that if you have, let's say, a posterior cranial lesion or something in the brainstem can affect balance, or things like the cerebellum, which is kind of located in the back of the neck, can affect balance. So I think there can be a number of things that can cause it. And things like neck-tongue syndrome, when you just turn your head to the side, that can cause headache. So even just changes in head position, not even just balance, can actually be related to headache. Now, is vertigo a symptom in every single type of headache? I don't think so. But I do think it can be part of that kind of spectrum, of issues. And when you see vertigo, then, or balance issues, or, different pathology or neurologic signs, then you have to start to think about a greater differential. Like you have to start, thinking about neurologic disorders, thinking about, where this could be coming from. So if somebody has balance issues, I would start to broaden my differential. That's probably the best answer I can give you. Can a lipoma cause headaches? I don't know specifically, but I have seen cases of what we call, oh, sorry, go ahead. I have seen cases of like what we call like giant lipoma, which can kind of appear in various places. I would assume it could cause a headache depending on the location, but I don't know of a specific case of a lipoma on the neck causing a headache. I haven't heard of that. Sure. Any other questions? Did that answer the question about the vertigo? I know that's a long answer, but it can be from a number of things. Any other questions? Okay.
Can you say one more time how patients or potential patients that maybe have more questions for you can get a hold of you?
Yes. So if you take a look, there's a website, neospine.com here. On the here, you guys are always welcome to give us a call. My email, I'm sorry, I should have included on the presentation, is just Batta. So my first letter N, my last name Batta. I'm going to write it here in the message chat. And you can email me anytime. And any of those numbers, on the screen, and I've just sent my email. So any questions, you can feel free to reach out. Any of these, I'm in Gig Harbor and Silverdale. So, calling those offices at 253-841-0842. That's also a way to schedule an appointment or reach me. But email, I'm pretty quick about responding, within 1 or 2 days for any patient questions. So feel free to shoot me an email at any time.
All right. So this webinar was recorded. For those of you watching, we are going to have it up on the YouTube channel. We're also going to be sending out an email wrap-up of this. We'll make sure to include Dr. Batta's email address for those additional questions. And I know sometimes these presentations can be a lot to take in, and so we thank you for being willing to share your contact information and your expertise with potential patients. Again, all this information will be on our IRG YouTube, and you'll be receiving a follow-up email. I want to thank all of you again for being so flexible and moving from Teams to Zoom. We appreciate your flexibility, and I think we still got an awesome presentation out of it. And thank you for your time, especially as you've been traveling today, and traveling back and getting back into the swing of things. So thank you again. And I think maybe just we'll stay a couple more minutes for some questions, and then everyone's free to log off and go have a great night.
Yeah, no, thank you guys again for having me. It's a pleasure. And I know I presented a lot of information, but, hopefully, you can read through it, and any questions you guys have, please feel free to reach out. I'm happy to clarify anything at any time. Yeah, any last minute questions for me? I think I can help answer.
Awesome. Thanks again. Dr. Batta, make sure to, when you stop the recording, make sure you do download that to your computer and send that off to us.
Okay.
And then Jensen will be in contact regarding some of that follow-up to make sure to get all the information out to the patients and just wrap up with you, okay?
Okay, so once I stop, I'll download and send it to Jensen. Okay, sounds good. We'll do.
That's perfect. All right, well, have a great rest of your night and be well.
All right, thank you.